Okay, we are moving to neck and trunk part 2. So this will be building on all of the bony anatomy we learned last time. So for this, ligaments. Basically, I just want you to know that your spine has tons and tons of ligaments. You don't need to memorize any of these ligaments, but you need to know you have ligaments in your spine. So you have ligaments covering the entire anterior side, you have ligaments going down the tips of your spinous processes, you have ligaments going in between all your spinous transverse processes, and you even have ligaments kind of inside that vertebral foramen or your spinal canal. So these ligaments are what are going to be injured if you have a sprain in your spine, or like what happens in whiplash. So you don't need to have any of these memorized, but just know that there are ligaments. It's on there. Okay, so what you do need to start knowing is your disc. So in between every single vertebra, we're going to have a disc. So that's what on the skeleton we can see these kind of jelly, orange, yellowy kind of little discs in between each side. So they are disc-like in shape, and they sit in between the vertebral bodies. So we have vertebral body, vertebral body. The disc has two regions. It has a nucleus pulposus and an annulus fibrosus. So if you remember from probably like your basic biology classes, the nucleus of a cell is always kind of the center circle. So the nucleus pulposus is going to be that center circle within the disc, and the annulus fibrosus will be the ring around it. So both the nucleus pulposus and the annulus fibrosus make up the disc, and different types of disc herniations depend on which region has herniated out. So maybe if the annulus fibrosus bulges out versus the nucleus pulposus fully herniates. So these discs are also going to absorb all of the kind of shock and friction. So again, if we think we never want two bones to be hitting each other, we always want something to be cushioned in between. So we have those discs in between each vertebra, cushioning, absorbing the shock. Okay. So our muscles. We're going to start with one of my favorites, the sternocleidomastoid. So the sternocleidomastoid, its name makes up the three bones that it touches. So the origin of the sternocleidomastoid is going to be our sternum and our clavicle. So we know our sternum is our breastbone down the center. Our clavicle are our collarbones. So the sternocleidomastoid is going to start on the very medial inside end of that clavicle in the sternum. So sternum, cleido is referring to clavicle. And lastly, mastoid. It is going to insert on that mastoid process, which I talked about last time, was that bump behind your ear. This bump right on the side. So this is that muscle, if you've ever kind of flexed your neck and those two muscles have like popped out in kind of a V shape, that is your sternocleidomastoid. So actions, you will see bi and uni. Bi means bilateral. So that means when both sides contract at the same time. Versus uni is unilateral, when only one side contracts. So bilaterally, when both of them contract, we're going to have neck flexion, so chin to chest. Unilaterally, we will have lateral flexion and rotation to the opposite side. So if the right side is causing rotation, you'll actually have left rotation. So it's the reverse. So you won't be having a right muscle contraction and turning right, it's the opposite. So it does lateral flexion, and then it does rotation to the opposite side. Okay, next are our scalenes. We have 3 scalenes, an anterior, a middle, and a posterior, but together they are just the scalenes. So you can see the sternocleidomastoid sitting on top of the scalenes, and we have our 3 scalenes deep to that on kind of the lateral side of our neck. And here it is with all the other muscles taken off. So the origin of the scalenes are going to be the transverse processes of the cervical vertebra, which we know are the sides, the blade-like projections coming out from the sides are those transverse processes. They are going to insert on your first and second rib. So you can see first rib right here, second rib right here. And your first rib and second rib are a lot higher than you think they are. So your first rib is actually directly underneath your collarbone. So it sits right underneath. So it's coming from the transverse processes on the side, inserting onto this first rib, second rib. So bilaterally, they're going to assist with neck flexion. They're not major neck flexors, but they do assist. Unilaterally, they will cause lateral flexion, so that ear to shoulder. Your scalenes are one of the muscles we'll talk about with an injury, thoracic outlet syndrome. But what's interesting about their anatomy, so they're on that lateral side of your neck. What super important structures are on that lateral side of your neck, or kind of right here? Why don't you want to get your throat cut? So you have arteries and veins, right? Your carotid artery. So that's why necks are so scary, because of all the blood supply. So a bunch of the blood supply goes directly underneath those scalenes, which you can see kind of sticking out here, some of it right here. When those are really tight, they pull on the ribs and actually can constrict the blood flow and the nerves as well. So we'll talk about that injury at the end. Next, splenius capitis. Capitis is referring to your head. So anytime you see the word capitis, you're going to know it's the head. So the origin is going to be one of the ligaments. So that's actually called your nuchal ligament. So your nuchal ligament is only in the cervical spine. It doesn't travel the whole spine. And it's basically this kind of fibrous tissue that goes from your external occipital protuberance, which we know is the bump in the back of our head, and it goes down to about like C7, T1. So it kind of just sits on top of all those spinous processes in your neck. So our splenius capitis, we can see right here with no other muscles on it. And we can also see right here. So the origin is going to be the lower half of the nuchal ligament, so the bottom region. And it's going to be on the spinous processes of C7 through T3. So that is C7, T1, T2, T3. So we'll have on our spinous processes, which we know are the tips. The insertion is going to be the lateral occipital bone, which we know is the back of the head, and the mastoid process. So coming up from here, going on to that lateral occipital and that mastoid process. So now you can probably see why, if your neck is really tight, why you get a headache, because so many of your neck muscles attach to various points on your head. So when those get tight, pulls kind of on your head, gives you a headache. So the splenius capitis, bilaterally, is going to extend the neck. So generally muscles on the anterior side are going to do neck flexion. Muscles on the posterior side are going to do extension. It's also going to do lateral flexion. And this time, it's going to do rotation to the same side. So if I'm doing right rotation, it is my right splenius capitis. If I'm doing left, it's my left. So unlike the sternocleidomastoid. Okay, so now we get to move into trunk. So these are where they may get a little confusing because this picture looks kind of crazy. So first is our rectus abdominis. This is what we're going to classically think of as our ab muscles. So you can see this is where you would get that like six-pack abs from, is your rectus abdominis. So what the abs are going to be kind of like. The red is going to be the muscle. The white is all going to be kind of like fascia, connective tissue, kind of like the IT band. So you can see the rectus abdominis is running straight up and down, but it has little tendinous intersections that run and cut in between. So that's what's giving you that defined like six-pack, the different like segments, is you have muscle and then you have tendon in between. So as this little muscle gets bigger, the gap, because the tendinous intersection doesn't grow, stays down. So it puffs up around it, making the illusion of looking bigger. So your rectus abdominis is going to originate from the pubis. So right in the front, that pubic bone. So starting all the way down here, pubic bone. It is going to insert on the xiphoid process, which we know is that tip of that sternum. So coming all the way up from pubis to xiphoid process. It's also going to be on the costal cartilages of the 5th, 6th, 7th rib. So costal cartilages were these kind of jelly parts, right? So we can always count down. 1, 2, 3, 4, 5, 6. So if we're going to do 5, 6, 7, 5, 6, 7. So costal cartilages of those ribs. The action is going to be trunk flexion, which would be, again, remember, curling down, touching your toes. Also, compression of the abdomen. So that means, like, if you were going to tighten up your core, suck your belly button to your spine, that is compression of the abdomen, holding in tight. And remember, rectus means straight, so that's why the muscle goes straight up and down. So that's some of the easiest way to identify these muscles is look at the direction their fibers are running. So next is going to be one of our oblique muscles. So we actually have two oblique muscles, not one. First, we have external oblique. This is going to originate on the lower lateral 8 ribs. So the last 8 ribs on the outside, so again, we would just count. It's going to insert on the iliac crest, so the top of the hip, and what's called the linea alba. So linea means line, alba means white. So your linea alba is this straight white line that goes down the center, your belly button's within it, dividing your abs into right and left halves. So that linea alba going straight down the center. So you can see our external oblique is this one right here or this one. So what you'll notice with the external oblique, so making it different from the internal oblique, its fibers run up and out. So you can see the fibers are going diagonally up and out versus the internal are going to go up and in. The action, so bilaterally, when they both contract together, they will do flexion because they're on that anterior side, as well as that compression of the abdomen, so kind of tightening your core. Unilaterally, they will do lateral flexion, so going down to the side. And the external oblique is going to do rotation to the opposite side again. So a right rotation will be the left external oblique. So the reverse of the external oblique is going to be the internal oblique. So what this image is also doing is it's cutting down the layers. So external oblique is on top, then we go to internal oblique and rectus abdominis, then we go deeper. So each of these sections is getting deeper. So the internal oblique is going to sit deep underneath the external. So the origin is going to be, a new one, our inguinal ligament. So our inguinal ligament is going to go from ASIS to pubis. So you can see right here, ASIS, we're going to have a ligament running straight down. This ligament is also what gives people the appearance of having that kind of like V cut in the front. It's because they have a tighter inguinal ligament, so the muscle builds up around it, and that inguinal ligament cuts a hard line. So the inguinal ligament is just going to run from ASIS to pubis. So it's going to come off that inguinal ligament, so off the side right here. It's going to originate also off the side of the iliac crest, so the top of the hip, and what's called the thoracolumbar fascia. So thora, or thoraco if you want, is thoracic spine, lumbar, lumbar spine. So basically what that means is it's going to wrap around posteriorly, and you'll have a broad kind of diamond shape of fascia kind of going from your thoracic spine to your lumbar spine. So you'll have like this diamond of fascia. So it wraps around and attaches onto that fascia. It's going to insert on our 10th through 12th ribs. So 12, 11, 10. So these bottom 3 ribs. And the abdominal aponeurosis, which is all of this white stuff. So aponeurosis is basically more fascia. It's all around. You have it a lot on your skull. So bilaterally, it's going to flex and compress, same as external oblique. It's going to do lateral flexion, same as external oblique. But internal oblique is going to do rotation to the same side. And you can see in their fibers, they're running up and in the diagonal. Now, if you've ever done an oblique exercise, it usually is a lot of rotation, right? So like Russian twist or something like that. So because they do rotations to different sides, if I did a twist and I was right rotating, I'm going to be contracting my left external oblique and my right internal oblique. So then when I go the other direction, I'm touching my external oblique, contracting my internal oblique. So that's why you do those twisting motions, so you get both sides obliques, versus if you just held at one side, you'd only be working internal, external. Does that make sense? Okay. So the last of these kind of ab muscles is going to be our transverse abdominis. So we know abdominis means abdomen. Transverse means horizontal, right? So rectus abdominis is straight up and down fibers. Transverse abdominis is going to be horizontal fibers. Now this is going to be the deepest of all of these. This is kind of like your true core muscle. So a lot of times when people say they're doing a core workout and then they're just doing crunches, not a core workout. Core workouts are going to be where you're just having a compression of the abdomen. You're not actually going to be moving a lot. So that transverse abdominis is the tightest. It kind of functions almost like a girdle or like a waist trainer, but it is the muscle. So the more strong that muscle is, the more it pulls everything in is tight. So its origin is going to be very similar to internal oblique. So that inguinal ligament again, so right here, our iliac crest, the top of our hip, the thoracolumbar fascia, that diamond shape on the back of the spine, but it's also going to come off our last 6 ribs. So we kind of just count up 3, 3, last 6. It's going to insert onto that abdominal aponeurosis. So you can see the kind of white right here. And that linea alba. So that line going straight down the center. The action of the transverse abdominis is only compression of the abdomen. So it's not doing a crunch motion, it's just when you tighten up your core, kind of suck everything in. Okay. So getting to move on to kind of our back trunk muscles, we're going to have our erector spinae. So this is kind of what you're probably most familiar with of your back muscles. So your erector spinae have a very easy origin and insertion to recognize, because if you notice, they're the exact same thing. So it is your spinous and transverse processes and all posterior ribs from occiput to sacrum. So what that means is your erector spinae are going to touch every single spinous process all the way up, and every single transverse process all the way up, all of your ribs all the way up, from occiput, back of your head, to sacrum, all the way down here. So they are traveling this whole distance, all the way. So this is the muscle you're most likely going to feel if you touch your back and you feel them kind of like tightness. I call them pencils because when they're really tight, they feel like pencils. So bilaterally, they're going to extend both the neck and trunk. So erect means straight up. So to stand erect, you need the erector spinae. So they're going to extend that neck and trunk. Unilaterally, so one side versus the other, they're going to do lateral flexion, so that's side bending. Within the erector spinae, you're going to have 3 muscles that make up the erector spinae. You're going to have your iliocostalis, which is the outermost. We're going to have our longissimus, which is the middle. And then closest to the spine, we're going to have our spinalis. So the way to remember them, the mnemonic, is I love science. So you always know spinalis is going to be on the inside, closest to the spine. So iliocostalis, I, longissimus, love, spinalis, science. Just the way we were taught in school. Helps sometimes. So those are the 3 that make up the erector spinae. Next, another one of my favorite muscles, the quadratus lumborum, which sounds like a spell. It is abbreviated or sometimes called your QL. So you've probably heard QL before if you have back problems. Your QL is this muscle right here. So sitting deep underneath your erector spinae. Its origin, it's going to come off of the iliac crest. It's going to insert onto the 12th rib, so your very last rib, and then the transverse processes of all 5 of your lumbar vertebrae. So you can see it really well coming off of here, 12th rib, as well as all those transverse processes. The action of this is trunk lateral flexion. So that kind of side bending. Something it also does is a hip hike. So if you've ever been able to kind of like lift your hip up, tuck it in tight, that is a hip hike, that is your QL. QLs get very, very tight and can be very, very uncomfortable and painful, and they're hard to massage out. You can do releases on them, but you have to be careful because there is a kidney sitting nearby and you can damage that. Okay, any questions on the muscles before I move on? We're going to talk about the fun stuff, some injuries. Okay. So these are the injuries we're going to talk about. You don't need to write all these down because I'm going to talk about them all next. So thoracic outlet syndrome, what's called torticollis. We have sprains. We have sciatica. We have our lordosis, our kyphosis, our scoliosis, our spondylosis and spondylolisthesis, which are hard to say. They're often called spondies. Spinal stenosis, our herniated discs, and our fractures. So starting with this first one, this is what I kind of alluded to when talking about the scalings. So your thoracic outlet syndrome occurs because you have all of the blood supply coming from your brain and all of the nerves going underneath your clavicle, but on top of that first rib. You also have what's called your brachial plexus, which is a bundle of all of the nerves of your arms that go right underneath this clavicle and sit in between that first and second rib and the clavicle. So in thoracic outlet syndrome, you will get a compression of that artery, nerve, and vein running between the clavicle and the first rib. So basically, there's not enough room in between the clavicle and the first and second rib, so it pinches off the blood supply, pinches off all of the nerves. So this can be due to anatomy if you just have a very small area, or it can be due to a tightened scaling. So when your scalings are really tight, they'll pull that first rib off, pinching it up. So there's a lot of tests to test for this that involve doing your pulse, but we're going to do one right now. So everyone needs to put their arms like this. So it's called ruse. You're going to sit here as fast as you can, flick your fingers, and then let me know if anyone's hands go numb. Anyone's hands go numb yet or getting tired? So you got to have your arm all the way up. Everyone still have their feeling? Good, then you don't have thoracic outlet syndrome. So a lot of times if you'll do that, people, their arms will go numb, or they'll start getting like one hand will go fast and the other one will be going a little weird. There's also some positions where we'll have people turn a certain direction, we'll feel their pulse, and then we'll move their arm back, and sometimes you'll feel their pulse will kind of go away. And that's how you can tell. But a lot of times if people have a lot of all of a sudden they have nerve pain down their arm, their fingers are getting numb, sometimes the first place to look is their neck. Make sure nothing is too tight in their neck. So torticollis basically means turtle neck. So this is a deformity actually seen in babies where your head will be kind of laterally bent to one side and rotated to the other. So I'll have like my ear to my right shoulder, but my chin will be rotated to the left. So this can happen when you have an overcontracted muscle. So a lot of times you'll see babies who are born and they're just kind of stuck like this. And they actually have to go through physical therapy to try to stretch that muscle out to get their head back in line. But acute torticollis, so acute basically is an injury that kind of like just happened. Acute torticollis is what happens to you guys. Have you ever woken up and you can't move your neck? That's acute torticollis. As you get older, you'll have that happen a lot. So that's what happens when you twist or move your head too far and you get a bad muscle spasm and you get kind of stuck and you have that stiff turtle neck. So acute torticollis, turtleneck. Okay. So sprains are going to be most common in the cervical spine. You're not often going to see sprains in your lumbar or thoracic spine. They can happen, but you're mostly going to see it in your cervical spine. Can anyone guess why you would see sprains more often in your cervical spine than your other areas? cervical spine is going to be more mobile, more movements are going to occur there, it's less stable. So our lumbar spine is a lot bigger, near larger areas. It's kind of the stablest part of our body is kind of our pelvis. So as we get to more mobile areas, the more likelihood we're going to have an injury. Cervical sprains are going to be most commonly seen in whiplash, so from a car accident or even in contact sports, so like football, if someone gets kind of blindsided, or I've even had it in soccer when someone went up for a header and they got blindsided and hit, you're basically unable to control the movement of your neck, so you get impacted, thrown forward, come back, and it will tear all the little ligaments in between all your spine. So whiplash is going to actually be a cervical sprain. So then we're going to have sciatica. So this is going to can be from an impinged nerve root or from a piriformis muscle tightness. So has anyone ever had sciatica before? Where you have kind of nerve pain shoot down the back of your leg and go into your foot? You guys are relatively healthy. So that sciatic nerve is coming off from kind of the L5-S1 area. It's going through this pelvis. Your piriformis, that muscle we talked about in your 6 deep external rotators, is going to sit on top of it. It's going to go all the way back down the back of your leg. And once it gets to your popliteal region, the back of your knee, it's going to split off into a nerve that goes down the back and a nerve that comes down the front. So when you have an impinged nerve root, basically where the nerve originates from the spinal cord, so usually from a bulging disc, you may get that sciatic symptom. So you'll have kind of shooting pain is a classic sign of a nerve issue. So shooting pain, numbness, tingling, or sometimes I call it the hot water or boiling water sensation. You'll all of a sudden feel like you have boiling hot water gets poured down your leg, but there's nothing there. So this could be caused from a nerve root issue or from the piriformis muscle tightness. You'll hear about sciatica in people who have to sit a lot. So generally, people who have standing desks at work, they can get doctor's notes to get a standing desk because it helps with sciatica. So we already know these. We already know excessive lordosis, excessive kyphosis, and we know scoliosis already. But we don't know the spondies. So there are 3 spondy injuries, Spondylosis, you can just write spondy, spondylolisthesis, and spondylitis. They're all varying degrees of the injury, so one is worse than the other. Basically, what a spondy is when your spinal column shifts anteriorly. So basically, you'll have some of your vertebrae are sliding off of one another. So they'll be shifting forward. So in a traditional kind of spondy, you may have like an inflammation and it's sliding forward. And then as you get worse and worse, you'll actually have fractures. So the front of your vertebra will fracture off the back of your vertebra, and it's just going to keep sliding forward. So spondies are pretty bad. They're seen more in the physical therapy realm, less in the athletic training realm. Okay, spinal stenosis. So stenosis in anything is going to be a narrowing of something. So in spinal stenosis, we know that our spinal cord runs inside that vertebral foramen, so that hole in between, and our spinal cord runs inside of it. With spinal stenosis, that spinal cord area gets compressed, so it stenoses. It either gets kind of a buildup of bone inside, or we have our disc bulge into it. Basically, it just makes the area your spinal cord runs in smaller. So this can be pretty dangerous if it's not fixed because it can result in permanent damage to the spinal cord. You see this a lot in actually football players, especially in football players who like to lead with their head. So they get a lot of axial loads resulting in an overgrowth of bone, which is just another reason why you shouldn't lead with your head. So herniated disc. You can have a bulging disc, and that isn't a herniated disc. So a fully herniated disc is when that nucleus pulposus herniates, comes out of its little region, and then it compresses on the nerve root. So all the symptoms from a herniated disc are coming based off of what the disc is pushing on. So most of the time they're going to herniate, kind of push onto that spinal cord or to where the nerve comes off, which is the nerve root. So a bulging disc would just be a small bulge, not a complete herniation of the nucleus pulposus. And then, of course, we're going to have fractures. A lot of times, spinal fractures are compression fractures, so pushing down on one another, kind of shattering it as it pushes. You're generally only going to see this in severe injuries, or some people may have a stress fracture in their spine, but maybe you're probably not going to see this in your common practice. Okay, that is it. Thank you for actually staying and not walking out. And you are free to go. Next time, I believe we're going to do neck and trunk Jeopardy, and then you'll have a quiz posted on Canvas right after that.